Well, I want to welcome all of you to the second of our 3 sessions for the Azusa Pacific School of Nursing Research Symposium webinar. This evening, we have 2 presentations. They'll be 45 minutes in length, which includes a question and answers. The chat function in Zoom has been disabled, so please submit all your comments and questions in the question and answer section. We encourage you to submit your questions and comments on the presentations as early as possible, as our host will be summarizing themes and questions for our presenters throughout the presentation. So at this time, we will begin, and I'd like to introduce our Associate Dean, Dr. Grace Moorfield, so that she can introduce our first guest, our first speaker, Dr. Mary Gaffney.
Welcome, everybody. I am privileged to be able to introduce our first speaker of the evening, Dr. Mary Gaffney. She's an assistant professor in the School of Nursing at the University of South Carolina, Aiken. She received her Bachelor of Science in Nursing degree from St. Olaf College and her Master's of Science in Nursing and Doctorate of Education degrees at Walden University. As a full-time educator, she teaches fundamentals, the lab, and nursing research course. She also serves as faculty mentor for numerous honor students and their research projects. Her research interests include quality improvement, nursing education, active learning strategies, and more recently, the effect of COVID-19 pandemic on nursing education and on healthcare workers. Prior to becoming a full-time educator, she worked as a pediatric critical care nurse for 30 years at Children's Hospital in Georgia at the Augusta University Medical Center. She continues to serve on the Hospital Ethics Committee. Dr. Gaffney is a member of Pi Lambda Kappa Sigma Theta Tau International. Welcome, Dr. Gaffney.
Thank you so much for this opportunity to present a little bit about my research with you tonight. I really look forward to any of the comments and the questions that you might have. I'm going to take a second here to get the appropriate screen ready for you. Okay. I believe you can see my screen now.
That's perfect, Mary.
Okay, very good. All right. One more thing here. Okay. So what I would like for us to do this evening, I can get this one more thing on the computer screen. There we go. Okay. So what I would like for us to be able to do by the time we get to the end of this presentation is to think a little bit more about what is going on with the healthcare provider, both before and after the start of the pandemic. And I wanted to look at some of the risks, not only to the healthcare providers, but also to the healthcare system as a whole. And possibly there will be some positive outcomes from going through this as a healthcare provider. So let's see what we can find out. So let's start a little bit with the non-pandemic or the pre-pandemic reasons for why people might go into healthcare. Many people, as you may imagine, they go into it because they have a sense of calling, or they have a mission. They have this altruistic feeling. They want to help people. And so they tend to go into these professions because of their love of humans and humanity. Another reason why people go into it is because of the job stability. And as you are aware, as nurses and other healthcare providers, there's really a huge shortage now of nursing staff, and also medicine. We're having quite a bit of trouble getting enough physicians to work in rural areas in particular. Job satisfaction is another reason people stay in there a lot, or stay in a long time because they do enjoy their job. Then also the pay and the benefits that they might have. And as you know, in the US, it's definitely pay and benefits are really important, particularly the benefits that we can have access to healthcare. So why do people leave healthcare professions? And this is, again, the pre-pandemic nurse or other healthcare worker that you might be thinking about. It's really easy for nurses in particular to reinvent themselves, especially if they become disillusioned with something. And we know that a lot of nurses, they get into it for a year or so and they have a really difficult time with that transition from school into working. And that adjustment's really difficult. And a lot of nurses will get out of the profession fairly soon if that experience has not been particularly positive for them. Also, if nurses are having to deal with chronic inadequate staffing, then that does take a toll as well and contributes to that poor or unsafe environment. We also know that nurses suffer quite a bit from burnout, and we're really particularly concerned about that now because it ties in with compassion fatigue and with other aspects of just the general well-being of nurses and other healthcare providers. And also, people are afraid of litigation, so they oftentimes will get out because of that. As far as the professional situation goes, we have sometimes where people don't see that they're going to be able to advance very far in their career, particularly with regard to pay. And what we know is that nurses in particular, they go in at what seems to be a fairly high rate of pay, but then afterward, within about 4 or 5 years, they might actually have maxed out what their earning capability is. So it's a bit of a shock when they compare perhaps with some of their peers who are farther out in their career and they are not making as much as their peers might be. And then the climate also may limit that feeling or that sense that you can grow or that you can belong and have ownership in what's going on. And that tends to be more of an issue when we have problems with a collegial or an interdisciplinary work environment. So what could be happening now with our healthcare providers during the pandemic times? Well, or pre-pandemic times. So why did people want to leave before the pandemic? So people who had less than 4 years of practice were more likely to leave. They also, if they worked on units that were related to pandemics, where they actually took care of that disease specifically on that unit, then those are nurses who would in particular want to get out of that environment. If they had fear for themselves or for others, so these might be people who would worry about taking the illness home to their loved ones. You may have seen stories on the news where they're talking about how the nurse or the physician comes back home and they haven't seen the kids for 2 or 3 weeks or 2 or 3 months. And there's all these reunions that are happening as a result of people trying to protect themselves and others. There's also a really heavy emotional toll because of the heavy workload, and especially when there's a high death rate. And so we know that that leads to burnout. And we also know that from previous pandemics that nurses, or not nurses as a whole, but all of healthcare workers tend to see a good bit of PTSD. And it can be anywhere from 10 to 50% of the individuals involved in caring for that patient population. So we do see PTSD and in non-pandemic times, and we tend to see that more often in our high acuity settings like trauma units and ICUs, places where we might expect that there would be a lot of death. But we're also seeing that in situations where they might encounter moral distress or moral injury. So when it comes to the healthcare provider during COVID, we have to think about, were we really ready? Did we know what our organization's plan was for an event like this, a catastrophe or a disaster? I don't know about how it is for many of you, but I never really knew what the disaster plan was at my institution until I was on the ethics committee. So that was about 2/3 into my time at the Children's Hospital. And I thought that was really a shame because I wasn't prepared mentally for what might happen if there was a hurricane to come through or some other disaster. And that was even just for a short period or a short disaster, such as a hurricane. We also weren't really stocked up well enough on PPE, which I think that's been sort of the global cry from healthcare providers, in that we just didn't have enough of what we needed for that. And then we've also had to deal with more staffing shortages. And you may think about this from the standpoint that a lot of people, when they realized how much money they could make traveling, they quit their jobs where they were. And so a lot of institutions lost experienced staff because of that. And so the brain drain, as well as the loss of capable people, really added to that stress and to the staffing shortages. And then, of course, we have the politicization of the pandemic. And I did find out a little bit more about that as I moved through my research. Now, what do we think about when we think about our preparedness from the standpoint of someone who is in healthcare? And I guess my question for you might be, how, when we are preparing people for from an educational standpoint, we're looking at knowledge, skills, and attitudes. But from the COVID standpoint, maybe we needed to look at it from the physical, emotional, and cognitive standpoint. Did we have people who were prepared to address what came from COVID and all of the issues that came through? So we had people who maybe were having a lot of problems with the physical aspects. The PPE certainly added to the fatigue and to the distress that people physically encountered. We know that they had problems with dealing with the emotional aspects, and that their coping skills were really challenged. And then also we had a lot of staff who were having to upskill and take care of patients who were really out of their comfort zone. So all of these things really got me thinking about what could be a trigger for why people might not want to be in the healthcare profession after the beginning of the pandemic. And the thing that triggered me, well, actually we had two events. One is that in April of 2020, we actually lost a student to COVID. And so that I was beginning to think about what would the effect of his death have on our fellow students, and might that be something that would dissuade them from wanting to be in the healthcare profession after that. And then we also had a colleague who was an alumna, and she died from COVID. I want to say it was in the fall. And again, these were things that challenged a lot of our faculty and challenged a lot of our students when things got a little closer to home. So I had two hypotheses for this particular study that I did. One was that I wanted to know what the what specific demographics or characteristics about our healthcare providers might lead them to thinking more about leaving the healthcare system. And I also wanted to know if fear in particular was a factor in their decision or their thoughts of thinking about leaving the profession. So I did a cross-sectional exploratory study that was basically a very broad sample of individuals that I got from all healthcare professions. Some were licensed or qualified, depending on the country, and others were not licensed or they were merely certified. So there was a good representation from the perspective of having individuals who were higher educated as opposed to those who were less educated. And then I had a recruitment letter that basically I posted on social media, and I had a QR code that they could scan with their phones, and it would take them to the survey. I posted all this onto Facebook and to LinkedIn and a couple of other organizations, but basically using social media, I was able to attract my participants. The survey that I administered was about 20 questions, and it had 11 that were demographic, and then there were 8 that belonged to the Schumenti multi-dimensional assessment of COVID-related fears. And that was a total of 8 items that were multiple choice. And then there was one short answer question for the participants to tell me what their thoughts were about working during COVID. So I asked specifically about their age, gender, country, where they lived, their profession, and how long they've been in healthcare. I felt that, especially for the profession and the healthcare experience, that might be important to know, as well as the care setting. So was it acute care? Was it critical care? Was it outpatient, or was it a long-term care facility? And then I also wanted to find out what, as best they could remember, what their thoughts were about leaving the healthcare profession before pandemic times, and then finding out again during the pandemic. And the survey was administered in the first 2 weeks of September. Other demographic items that I asked had to do with the finding out if they had lost a family member or friend or a coworker directly due to COVID. So for those of you who have your cell phones handy, if you would, I'd like for you to scan this code and see if you can take the survey for me. It's just going to ask you those 2 questions. And I'm just curious about our audience tonight to know if you guys are, if you've had the experience of losing people to COVID. I'm going to let that sort of do its thing for a while.
Mary, do you want me to ask a quick poll question?
No, it's okay. I'm gonna I've got it on my iPad, and I'm just gonna tell the numbers later.
Perfect.
Yep. Okay, thank you. All right, so just to give you a little more information about Schumenti's multi-dimensional assessment of COVID-related fears, we'll call that the MAC from now on. It has 4 domains of fear that it's going to be looking at. It's going to look at the bodily domain and the interpersonal domain. So those are 2. Basically thinking about the fear of your body either failing you, or that you might come into contact with something that could infect you. The interpersonal, where you're worried about people around you, or that you might become where you would infect someone else. Then you have the cognitive domain, where you're thinking about it all the time. You either have too much information or not enough. And then the behavioral domain, where you feel like you have to be doing something all the time, or you feel paralyzed because you're afraid you'll make the wrong decision. So I wanted to find out if these domains of fear would register in any way with the experience that these folks had had, and if that would flavor in any way their decision to leave the healthcare profession. So I had a pretty good representation of especially the nursing and the allied healthcare professions in terms of the male to female around the globe, Australia, England, US, Canada. The percentage for men to women is about the same here, so as what we have in the US. So it's about 13% male. The age range of our participants was really a pretty even distribution, with the exception of the youngest group, that actually surprised me a little bit, because I was thinking that that group would be much more inclined to, or would be more attracted to use social media, and would take the survey because of that. The count, or the countries of residence, as you can see from the slide, I had quite a few responses that came through. Predominantly, these were from the USA and Canada. I got quite a few from England, and then from Australia and New Zealand. Unfortunately, I did not get anyone from Italy, and not so many from Spain. And I was really hoping to get more from them, simply because I knew that they had hot spots and that were sort of the leading the way in the pandemic, and I wanted to get their sense of their experience. So I had a predominant response to the nursing profession, or to nurses. I also had a lot of pre-hospital or EMS people, and rehab services and allied health, good representation from them, considering that I had difficulty getting access to those social media website groups. Let's see. Years in the profession, the folks who were in for less than 2 years, I'm thinking probably has more to do with the fact that that age group, the youngest age group, also did not really participate very much in the survey, but the rest of the participants really were pretty well distributed across the professional lifespan. And I did have a few students who actually took the survey. What I found was that there was predominantly exposure to critical care and acute care in the participant pool. And I had a lot of people who were providing direct patient care. So the majority by far were providing direct patient care. The individuals who lost family members or friends to COVID was about 12%. And I'm seeing from the group here, 35% of you lost a family member or friend to COVID. So you guys have certainly experienced much more in your community than perhaps was represented by the other participants in my study. And then those who lost a colleague or a coworker to COVID-19, 16% of the respondents had, and in yours was 14%. So that was a little closer. Now, the questions that I really were most curious about had to do with the thoughts of career choice regret before or after the beginning of the pandemic. And as you can hopefully tell from this little diagram here, everything really shifted dramatically from one end of the spectrum to the other. And folks who never thought about leaving the profession suddenly seem to be wanting to leave, and vice versa. People who often thought about it, that grew quite a bit as well. So that made me a little concerned for what might happen to our future in healthcare. The inferential statistics that I did some regressions, and what I found really was that the age was not an issue. The where they worked was an issue in the sense of, was it acute care or critical care? But those who worked in the long-term care, those folks did not have an appreciable change in their thoughts about leaving based on where they were, excuse me, where they were working. The death of a family member or friend was where we had some findings, and I was really surprised that I did not see that the loss of a coworker would affect people and their thoughts about leaving the profession. And then the domains of fear really did not show anything to me that was of any significance. Now, I did ask the participants to tell me a little bit about their experience, and I asked them specifically, just give me 2 or 3 words to describe, and for many people it was a catharsis. I also had a few that messaged me to say they were glad that someone was finally interested in hearing what they had to say. So with that at the front, I started analyzing some of the themes here. And so I came up with a half a dozen or so of them. So fatigue was the one that was just overwhelmingly, it was really amazing to me to see just how tired people were, and to hear the ways that they described their exhaustion, and to be spiritually, emotionally, and physically exhausted. That just That was very powerful to me. The next was fear and vulnerability. And they were worried about infecting others, like family members and friends, and perhaps even other patients. But they described the experience as in ways that it was an emotional response. It was a response to how they got to where they were without PPE or without having adequate staffing. And ultimately, they just felt powerless. The third theme that I have is anger. And this by far was just really a point where I could see that people struggled with maintaining their composure in how they interacted with their employers and with their administrators. And I had on more than one occasion where the respondents had said that they do not enjoy their jobs any longer. We also had some doubters, and those doubters, I was amazed, and I haven't done this yet, but I think I need to go back and look and see what type of care area they were working in, if it was in an ICU or if it was in an outpatient setting, because I think if they had worked in an ICU, that perhaps they might have had a different take on this. So I have a little bit more of a dive I need to do into the data, but to have people that were still not sure if this really existed was concerning in many ways. I also had quite a few people who described how the experience left them fulfilled and that they were so honored and really privileged to be there with people during such a difficult time. And they spoke highly of their colleagues in that same setting as well. And that they celebrated their triumphs when they could. And then we had quite a few folks who talked about the pandemic as basically a journey. It was a dichotomous experience for them. One said, it has been incredible to watch and be a part of not knowing and then evolving into being a well-versed group. And I had another that said, it has been a constant change of events and moving from not knowing into knowing. So what does this really mean for us now? My key areas that I would like to focus on have a lot to do with the restoration of the trust between organizations and the healthcare workers. I think that we've lost some of that based on the comments that I saw. I think that there's a lot of opportunity there for our hospitals and other organizations to come up with ways to address some of the baggage that people are going to be carrying for a while that had to do with the anger and the disappointment that they felt. I also think there's going to need to be some, basically, they're going to have to repair relationships with staff members who left the hospital to travel and left the remainder of the people behind to deal with with what was left in their wake, essentially. And then the public trust is going to need to be restored in places where it was lost, and then particularly with our public health officials, because I think that they've had a lot of struggle during this time as well. So what can we think about here with our healthcare providers? Well, we've got a whole lot of issues that we're going to need to worry about here. We know that moral distress and moral injury have occurred. The concern for post-traumatic stress disorder, post-traumatic stress syndrome, basically any of the folks who are working in this high acuity, low staffed or high mortality areas, those are folks who have undoubtedly seen lots of badness, for lack of a better word. And so they're bound to be distressed. We're going to have a lot of folks who are burned out from this. And I did see that comment several times in my in the responses I got. And then we have a lot of folks who are dealing with grief. And that grief has to come from losing their loved ones or their coworkers. And I suspect that many people have really not had an opportunity to process a lot of that. On the good side, though, we have good news in the sense that the nursing schools have been seeing an increase in their applications, and some have actually been able to increase their enrollment. This has happened also in some other allied health professions, and we know that we're always looking for ways to get other individuals involved in brought into the profession as soon as we can because of the need that we have at this point. So this is definitely a encouraging finding, or I guess outcome of all of this. The other thing is, what did we gain from all of this? And I had a few comments that talked about the opportunity for creativity and team building and how they felt so privileged to finally have interdisciplinary respect, or the respect of the public. And some of the comments about the respect from the public came not just from the US, but from places like Germany and from Australia. I think I got one from there as well, which I thought was interesting. That there was the concern about how the public might perceive them. And, you know, we've seen a lot of the healthcare heroes, and we hear that term tossed around a lot, but what does it mean really now to be a hero? So I would love to take questions from you now.
Thank you, Dr. Gaffney. I just am very appreciative that you're here sharing this very important research with us. We have a couple of questions, and if anyone else has questions, please go ahead and type them into the Q&A section. Our first question is actually a comment and a question. It says, inadequate nurse staffing is one of the issues faced by health institutions worldwide. What can be done to decrease the number of nurses leaving the profession?
Ooh, that's a multifaceted answer that's going to be required for that. I think we have to help people recognize that nursing is no longer just going in and holding someone's hand. And in some ways, I'm concerned that we're moving away from that. But I'm not sure that people really know what goes into healthcare other than what they see in the media. So what they see in the media or in other ways has to do more with what they see on Grey's Anatomy and in some other healthcare shows that really are not accurate representations of what we do. And I think people would be more interested in healthcare if they saw actually what we did and realize that it's an opportunity to take care of the whole person.
Thank you.
Okay, there's a second question. There were a few Latin American countries. Were they also included?
Yes, I grouped the Latin American countries in as a North American group, essentially. I was hoping to get more from maybe Mexico and Brazil because I had tried to get into groups down there, but it was difficult to recruit from there. I would very much have liked to have had better representation from South America and Central America.
And our next question is, you mentioned nurses had feelings of anger during the most difficult time of the pandemic. How do you feel that relates to the administration's support or lack thereof and care of the nurses?
Okay. Their anger, I think, was two-pronged, what I saw. One had to do with the fact that they felt like they didn't know what they were supposed to be doing because we had warning for the pandemic. Basically, we knew it was coming. We had a few months to get ourselves organized, hopefully. But the real anger came with the fact that one of the comments in particular was the administrators went home every night and they left us to take care of the mess. And they felt that was it made them angry because they felt like they were not respected, and they felt like they did not recognize that the problem was so, that it went on more than just one day.
So here's another question. You had faculty and student participation. You had some students that participated. Did you have faculty participate, and or was that even looked at?
I did not look at them as far as were they academic or were they totally bedside or clinical. All I looked at was the profession and where they practiced. Now, I did have a couple of people who put in comments that they were faculty, but that their practice area was in critical care or geriatrics or wherever their home base was.
Thank you.
Mm-hmm.
Was there anything from this study that surprised you? And if so, why?
I was really surprised that the death of a coworker was not likely to make people want to leave the profession, because to me, it seems like if my partner in crime over here has died, am I going to get it too? Is this going to happen to me? And that was not all the response that I was expecting. I think there's a part of me that thinks that someone would say, well, if they'd taken better care of themselves, they'd worn their PPE correctly, had they done this or that, they'd sort of blame the person. Is the only explanation I can offer for that. So I was really surprised by that.
So looking at PPE, the lack of PPE is a product of, and this is quote unquote, just in time product chain to save money. What recommendations do you have in regards to this?
Oh, well, we've got a huge healthcare system, and we tend to work in silos, and those silos make it difficult oftentimes for us to plan for these sorts of events, because we're not looking at the whole picture when we're working in silos. So I think there's got to be much more, cross-silo collaboration. People need to start sharing what they know and working with each other that way. So what recommendations? Like I said, that's a huge system-wide problem.
And we have one final question here. I think you already addressed that you didn't differentiate whether they were students or faculty in your survey or in your study, but the question is, did you have any new grads students take part of the survey, and how were their responses different from nurses with a longer time in their career? So do you have any plans to perhaps study that in the future?
I think it would be a really nice opportunity to study something like that. I've actually been trying to figure out how I can look at our cohort of students who, from 2020, look at them and, when they lost a lot of clinical experience due to having to go onto the virtual world, looking to see how that affected them and their response to caring for someone during a pandemic. How will all of that flavor their decision to stay in healthcare? How will that flavor their enjoyment that they get from taking care of patients and from being engaged with other healthcare professionals? The new grads, I think there's a really rich possibility for what we can learn from those folks at this point. I think that it's going to amplify a lot of the things that we do really well in terms of preparing students and how the institutions who hire them help them along. But I think it's also going to highlight a lot of the things that maybe we could improve upon, whether it's in education or on the front lines.
Thank you, Dr. Gaffney.
Okay, thank you very much, Dr. Gaffney, and for all of you that have participated with your questions. One of the things that has been a special priority for us this year is not only getting the experience and perspective within the United States, but also other countries around the world. Our next speaker will be contributing to that. Lindsay Haskett has been a nurse educator at Indiana University since she completed her MSN in 2018. Her interest in global health took her to Sub-Saharan Africa, where she was a clinical adjunct faculty for IUSON and visiting professor at Moi University School of Nursing in Kenya from 2018 to 2019. She's also a member of the Consortium of Schools of Nursing affiliated with the academic model providing access to healthcare, and collaborates with nurses in Kenya to research methods of nursing care excellence and education. Currently, she is a nurse educator at the Indiana University School of Medicine and is based in the Department of Surgery. Her clinical background and areas of expertise are surgical critical care and trauma. She will begin PhD studies in May of 2021 at the Indiana University School of Nursing. And if that doesn't work out, Lindsay, we have a great doctoral program here at Azusa Pacific. She plans to study social determinants of health with a minor area of study in nursing education. And both of those, of course, are very important to what we're experiencing with this pandemic. So we'll turn it over to you, Lindsay.
Thank you, Dr. Wood. Can you hear me? Okay.
Yeah.
Great. So I'm Lindsay Haskett. Like Dr. Wood said, I'm a nurse educator from Indiana University. Thank you all for joining us today and for giving me the opportunity to speak with you. I'm really excited to share the study that I conducted with some of my nurse colleagues from the United States and from Kenya. So we'll talk about our study titled Vicarious Trauma Among Frontline Nurses Caring for COVID-19 Patients in 3 Countries. And after listening to Dr. Gaffney's presentation, I think that there's lots of really important parallels and connections between her area of study and my area of study. So the nurses that I've collaborated with on this study are from Indiana University, Moi Teaching and Referral Hospital, and Moi School of Nursing, and the University of Texas at Austin. And like Dr. Wood said, we work very closely with the academic model providing access to healthcare in Western Kenya. And I don't really have anything to disclose about funding for my study because there wasn't any. So nurses are the largest percentage of the world's healthcare workforce. Wherever you go, wherever you travel, you go to a hospital, you go to a clinic, the highest percentage of people caring for patients are nurses. And this is the same before COVID. This was the same during COVID. And very interestingly, 2020 was deemed the year of the nurse. And nurses were making headlines all over the globe. They were called essential, they were frontline workers, they were often even called heroes and first responders during the initial stages of the COVID pandemic. In those early stages, you really couldn't open your phone and look at the news or watch the news on the television without seeing headlines of how people were thanking their first line responders. So people were giving free food and they were getting discounts and all types of things for nurses and other healthcare workers in the early stages of the pandemic. It was common in lots of areas of the United States where you would drive through the different areas and see where frontline providers, especially nurses, were recognized for their role in patient care during the pandemic. And you can see that in these signs, all of them include the word hero, which I think is very interesting when we think about how what nurses were doing during the pandemic differs from what they were doing before, because there isn't much difference, but we haven't really been called heroes until the pandemic. We see another, comic strip here, nurses being called heroes. And I'm really glad in this comic strip that the nurse is wearing a pair of pants and not a skirt. because they always show us in the traditional skirt with the little tiny white heels, and we all know that that's just not really a reality. This comic was one that was affiliated with Marvel, released in 2020. And I show you all of those things because despite the recognition that nurses received during the pandemic, there is a stark contrast to the experiences that they were having at the bedside. They experienced stress, fear, fatigue, isolation, and ongoing emotional trauma. Their experiences of sadness, grief, and death with patient suffering is not uncommon. Nurses are often at the bedside when patients receive bad news, or they're experiencing pain, or even when they take their last breath. So this may have been new for some nurses during the pandemic, but a lot of nurses were not unfamiliar to witnessing these types of things outside of their normal role as nurses. You know, nurses spend more time pre-pandemic, you know, during the pandemic, but they're the ones that are in direct contact with the patients most often. They communicate most often with the family more than anyone else from the healthcare team, which means that they are exposed to this witness and suffering and this death more often. And we know that reliving these experiences leads to lingering symptoms. This repeated empathetic engagement makes nurses vulnerable to physical, emotional, and psychological stress. These encounters often cause prolonged symptoms that, you know, we often think of this as post-traumatic stress disorder, right? So you're sad, you have guilt, helplessness, or even major depression as a result of your job as a nurse or things that you have experienced in your life. And so when we think about what was different during the pandemic in terms of these traumatic experiences, it was really this lack of resources. With the acute influx of patients at hospitals all over the world, there were not enough nurses to care for all the patients, especially when you think about how sick the patients were and how high the acuity was. The nurse to patient ratios were higher than normal, perhaps would be considered unsafe. Some hospitals didn't have enough ventilators, supplemental oxygen, and of course we know there wasn't enough PPE to take care of the patients. In some situations, there weren't even enough beds to admit people to the hospital that needed to be admitted to the hospital. And so we're looking at institutions, physicians and nurses rationing their resources. And this is very unusual, especially for nurses in the United States, where we do not often find ourselves faced with the decision of, okay, there's one ventilator and two patients. How do we make the decision of who's gonna receive, mechanical ventilation? And so this was different for a lot of nurses, but they were still at the bedside caring for these patients. And this really puts them at risk for moral distress. And knowing that a patient without a ventilator or without oxygen may die, and that their death would be without family due to, COVID restrictions. So this really changed those traumatic experiences for nurses during the pandemic. And so when we think about nurses witnessing the suffering of others and that indirect trauma, we're really thinking about this phenomenon known as vicarious trauma. And you may have also heard it called secondary traumatic stress. But this is different from post-traumatic stress. And post-traumatic stress, you are experiencing the lingering symptoms of your own experiences. So, for example, you've been in a car crash and you often relive the encounter of watching the other car collide with yours, or, waking up in the back of an ambulance. But this is very different when we think about vicarious trauma, because this is reliving the experiences of others. And so when we think about, PTSD, burnout, compassion fatigue, these are all very likely symptoms that were also experienced by nurses. But I want to be very clear and intentional when we talk about vicarious trauma, because the symptoms are very similar, but the phenomenon is in fact different. And those symptoms are, a lot of the symptoms that we think of when we think of depression and PTSD. So we're thinking of fatigue, loss of appetite, sleep disorders, so insomnia or sleeping all the time, irritability, fear, and interpersonal conflict. So we really, when we think about how difficult it is to tease these out, I think it'll be important to think about when we think about our implications for the future, how important it is to really identify these different phenomenon. And so nurses during the pandemic were really at risk for developing vicarious trauma due to a lot of different reasons, especially the unknown about the novel coronavirus. So if we remember, back to the early stages of the pandemic, people didn't know if they could, if they had to wear gloves when they left their house. What do they have to clean? Do we have to stock up on toilet paper? All of these things that were unknown really increased the likelihood that nurses were going to experience trauma during the pandemic. As Dr. Gaffney mentioned, nurses didn't, what are we supposed to do? What should I be doing? How do I protect myself? So, they're putting themselves at risk just for their job, thinking about putting the those that they live with or those that they care for, maybe elderly parents or children, spouses, roommates, putting all of those people at risk because they're taking care of COVID patients, and then experiencing, maybe all of this and being completely alone. So when, they have stay-at-home orders, nurses are still going to work, but then they come home and they might be alone, or they come home and they have a house full of people, students with online learning, or other responsibilities that were different because of quarantine during the pandemic. And then the death of patients. Nurses, traditionally, we know nurses would see patients die, but this was at an overwhelmingly increased rate during the pandemic. And then the death of doctors and nurses due to COVID, because they got COVID maybe from taking care of patients at the bedside, was very gut-wrenching. I personally experienced the death of a coworker during COVID. A nurse that I work with in my per diem job contracted COVID. She was working on the COVID unit and died, and she was younger than me, a very healthy girl. And so that was very challenging for a lot of the nurses that I worked with to continue to come to work and take care of these patients after that experience. And then also, I think it's really important to recognize the heightened media coverage that was really forcing us to look at COVID every day and think about the panic and the crisis that was being experienced. And even in the United States, we were in the midst of an election year. So all of these things really compounded this experience, but put nurses at risk for developing vicarious trauma. And so I really wanted to study what this vicarious trauma was, who was experiencing it, and really looking at is this happening? Because in my mind, I think it's happening. But of course, if we don't have the numbers, then we can't prove that it's happening. So we'll go out and get the data, right? So we also wanted to I wanted to study nurses in different countries because that's something that I feel really passionate about. They always, one of the phrases that you'll find commonly in global health is that global is local. And so to look at, what nurses are experiencing all over the world and find our commonalities can really help us to improve patient outcomes and to, further the nursing profession. So, really what I want you to think about being able to do is to describe and compare various vicarious trauma in the nurses from the different countries that we'll talk about, identify the risk factors associated with vicarious trauma, and then discuss the indications for advocacy, education, and future policy for pandemic preparedness to mitigate vicarious trauma in bedside nurses. So we created a survey utilizing the secondary traumatic stress scale. We added 5 questions to the survey specifically to address the COVID-19 nursing experience. And we asked the nurses if they had been redeployed to another unit, if they volunteered to be redeployed. We asked them if they felt that they had adequate PPE during the pandemic, if they normally experience death during their job, We asked them if they felt that their institution had effective infection prevention policies. And then we added one open-ended question to see if there were any themes or ideas that we might have been missing in our survey. And so we asked the nurses if they wanted to share in their own words how caring for patients during the COVID-19 pandemic has affected them. So we received the appropriate approvals to complete our study, and we recruited participants through social media. And we also used message boards through Sigma Theta Tau to recruit participants. The participants that we really wanted to capture were nurses that were at least 18 years old, caring for COVID-19 patients who were able to complete the survey on the internet and spoke English because the study was in English, or the survey was in English. We utilized hashtags to try to see if we could reach more nurses by utilizing hashtags. So we, tried to use some of the more common ones that maybe even non-nurses were using, so that we could try to capture a wide audience of participants. So our data collection was kind of a limitation to the study. And I think it's important to discuss this because we had an asynchronous nature of our data collection, and every country that we studied had a different peak of the pandemic. And so they were all at different points in the pandemic when we collected the data. And I think that this could be something that's a little bit of a limitation. So the peak in the US, at least in Indiana, where I was April to May, was kind of the worst period for us, one of the worst periods anyway. And then in April and May in China, things were actually slowing down, and they were seeing a lot of resolution at that time. And then when we collected data in Kenya, they had not yet started to see a peak in COVID patients at that time. And so I think this perhaps could have affected the results of our study. So we used SPSS for data analysis. We used descriptive statistics to look at our categorical and continuous variables. Then we reported them as frequencies, proportions, and corresponding percentages. We used Pearson's chi-squared test to look at associations between the categorical variables, and used a multiple regression to predict vicarious trauma with a stepwise analysis. And then we lastly use applied thematic analysis for our qualitative data from the open-ended question. So we ended up with 113 nurses responding to the survey initially, which we ended up excluding some of them because either they didn't complete the whole survey, or when we looked at where our nurses were coming from, we had 3 large cohorts, and then a lot of scattered, one nurse from Mexico, one nurse, we had 2 nurses from India. And so we wanted to really look at our 3 biggest cohorts. And so our 3 biggest cohorts were the United States, China, and Kenya. And so we ended up with 75 respondents. And really, this speaks to where our relationships are. We're affiliated with a school of nursing in a hospital in Kenya, as well as China. And, obviously we reached out to nurses here in the United States. So I think that's really why we had the most respondents from those 3 countries. So the first table here is really looking at the demographic of the participants from each country. If we think about level of education, it's kind of where I want to focus on first. Looking at the level of education, when we think about diploma nursing, associate's degrees, bachelor's degrees, master's prepared nurses, and doctoral nurses, there are some differences in the countries and the respondents, and I think that that's due to where we are in terms of nurses and nursing shortages. For example, in Kenya, there's still many diploma programs due to the tremendous nursing shortages, whereas in the United States, due to magnet recognition and a lot of other reasons, there's been a shift away from diploma programs and really pushing that bachelor's prepared nursing for a lot of different reasons. And I suspect that there's a similar shift in China also. Looking at nursing unit, we had a lot of nurses from intensive care and the emergency department. And we kind of put everyone else in one category because we had lots of nurses from those two categories. And then we had a wide array of nursing experiences, which one of the interesting findings is that I thought that we would have some associations between years of experience and nursing unit, and we actually didn't find any statistically significant associations. So when we look at the vicarious trauma score, here we can see that Kenya has the highest level of vicarious trauma, followed by the United States, and then followed by China. And I think there are a few explanations for this. And one thing I think is really probably due to our sample size. China's sample size was a lot smaller, which probably contributes a little bit more to the differences in their score. I think there are also some cultural differences to attribute as well, in terms of comfort in expressing displeasure with institutions in countries other than the United States. And so I think that could also have affected some of our respondents from other countries. And I think ideally, if we could do this again, we would want a larger sample size with equal representation from each country. And so that's something we would definitely change. So when you think about the vicarious trauma scale, everyone had mild vicarious trauma, except for Kenya. They were in that moderate to high category, which is interesting. And so we looked at also the questions that we asked to identify those factors that were unique to COVID that may have contributed to vicarious trauma. And really, there were no statistically significant findings among these questions in terms of just the overall responses. So, everyone kind of had the same experience in terms of, proper PPE and things. It looks like China, had a different response than the United States. And our questions were all on a Likert scale. So the answer, if they answered always, we coded that as a 1. And so a 2 would be, most of the time they had adequate PPE, et cetera. And so, this is probably the most important of our quantitative findings here. We found that a higher level of education and the perception of having adequate PPE were associated with nurses who have lower vicarious trauma scores in all countries. So these findings are not entirely surprising. I think there's a lot of, we can always try to draw our own conclusions, but some things that my colleagues and I have thought about is perhaps nurses who didn't feel protected from COVID at work were more likely to have more traumatic experiences and witness trauma more so than those who did have appropriate PPE, because there was more death and illness or more fear of death and illness. And then the finding of higher level of education is very interesting. And I'd really like to look at this more and look at, is this really due to a higher level of education, or is it due to the personality traits that are common among nurses with a higher level of education? So when we think about grit and resilience, and we think about how nurses who pursue more education, is it really their education that makes them have lower vicarious trauma? Is it their duties? Maybe they're not at the bedside. Maybe they're in an administrative role, and that's why their vicarious trauma score is lower. So I think it would be really interesting to look at some of those things in depth in future studies. And then when we think about our qualitative analysis, the qualitative findings showed us 3 major themes. And these were really challenges or failures in the healthcare system to respond to the pandemic. And, Dr. Gaffney mentioned some of these nurses' feelings in her study as well, and we'll talk about them in mine because they're very similar. The second big theme was nurses' internal struggles outside of work. So feeling that the stigma and the fear during the pandemic, and then those positive feelings about the pandemic, or experiencing some positive outcomes as a result of the pandemic. So the first kind of theme I want to talk about in depth is really this challenges or failures of the healthcare system that contributed to nurses' negative feelings about themselves while caring for COVID patients. So nurses felt that they were, nervous, obsessive, isolated, scared, morally distressed, were feeling guilty, were experiencing anxiety and pain and trauma. All of these words were words from all of the quotes that they typed in. And so thinking about, how they were really feeling about themselves, I think is really interesting compared to perhaps what other people were kind of labeling them as during the pandemic. And we'll get to that in a few more slides. But here is a quote from someone that they said, "I work in outpatient surgery and was told to either go to the emergency room or be out of a job. I went to the ER and got 3 shifts to train. My dreams were intrusive and dramatic every night. I don't feel supported by my hospital, and I have been actively seeking new employment." Another quote, "Initially, it was really hard on me. I was so scared, and often after the shift, I felt nervous and guilty that I might infect my family members. It was difficult relating to others. After attending to COVID-19 patients, I just felt like isolating myself. The most emotionally and physically trying experience of my life. Taking care for the COVID-19 patients, I think a lot about life, how to cherish and treat my relatives better." So our second theme of these internal struggles outside of work contributed to the nurses' fear, contributed to their feelings of fear, of disease and death, the stigma that nurses felt that they were experiencing. So maybe that they've been exposed to COVID and so people have to avoid them, or worried about getting their loved ones sick, and isolation due to quarantine. Lack of support from the healthcare administration was a really common theme throughout a lot of the quotes in terms of their internal struggles outside of work that were contributing to their feelings. This third theme, the positive feelings about the experience of caring for COVID patients, was that nurses felt that there was teamwork that really came from taking care of COVID patients. And so nurses felt that, they were really bonded with their coworkers and felt really confident in their role as nurses as part of the pandemic. But unfortunately, this was basically due to camaraderie among nurses, but not support from administration. And I think this quote is another really good representative of kind of these two themes together. And this nurse says, "As difficult and sad as the situation was, what was refreshing was the amount of teamwork that came out of it. The emotional part was seeing COVID-19 patients die without family at their side. They were never alone, as nurses never left their side while they were dying. We attempted to use iPads to FaceTime family. However, it is not the same as being able to hold their hand." And this is really striking to me personally. "The visual of your patient gasping for air as they take their last breath and knowing family cannot be with them is haunting." And so when we think about, the nurses' responses, we're looking at that nurses did not feel like heroes during the pandemic. And this is in huge contrast to, I think, what maybe the media was showing and what people may have assumed was happening. But none of the nurses mentioned that they felt like heroes. They didn't feel like they were saving lives. They cited breakdowns in the healthcare system, that they were told to reuse PPE that they had previously always been educated to only use once and then discard. They were forced to work on another unit, and we know that floating to another unit from time to time is a part of nursing, but being reassigned to another unit in the midst of a pandemic is probably very stressful. And then, at a time when there's a tremendous lack of resources, again, really is contributing to these feelings of breakdowns in the healthcare system, and perhaps, feeling unsupported by the institution really contributed to these negative experiences. And I think that, you know, one of the things that I'm sure you guys have really talked about in a lot of your different conversations during this meeting is that, you know, how do you really prepare for a pandemic? You know, how can we mitigate these experiences in the future? What are the policies that we need to make sure that we have adequate PPE? How do we drill down the lessons learned and prepare for the future? So, you know, I know someone asked Dr. Gaffney, what are the institutional, you know, what are the best practices for having enough PPE? And I suspect that the answer is that we don't know. And there needs to be more research on different strategies because all of these things have an expiration date. And we have never experienced anything to this magnitude for many years when we, you know, had a PPE. So what does that look like? And what's the best strategy to redeploy nurses to meet their needs during a pandemic? How do we educate them and acclimate them to a new unit in a very short period of time? You know, I've been a nurse since 2010, and I can tell you that when I go to another unit for one day, it disrupts everything that I think I know about nursing. I don't know the codes to get into any of the doors if my badge won't work there. I don't, you know, someone has to put me in the Pyxis so I can pull medications. I don't know the different physicians that I'm working with on that unit. I don't know any of my coworkers. And so I think that looking at how we educate and acclimate nurses during these times of redeployment is going to be really key in thinking about what these policies look like. And also, you know, educating nurses about the physical and mental risks of pandemic nursing. So what is vicarious trauma? You know, as a nurse at the bedside, I've never been told the risk factors associated for my mental health as part of my job. I do my annual competencies about bloodborne pathogens and how to use the, you know, the fire extinguisher. I can, you know, recite all of those things in my sleep, but what are the actual risks to my mental well-being from being a nurse, and what do we do about that? And so from a system standpoint, what do we do to support nurses, and not just the mental health support, but the administrative support during a pandemic? So should people be tested? How often should they be tested? Should we do mitigation testing? Should nurses receive paid leave if they contract COVID? Or should they have to use their PTO if they, you know, their paid time off? You know, do they have to pay to receive a COVID test, and et cetera, et cetera? So what policies do we put in place to really support the nurses? Aside from what are effective mental health interventions? Because I suspect that doing a web-based training that's mandatory is not an effective mental health intervention, which I find is what happens a lot when they think of providing education or, you know, providing support to nurses, is they want you to watch a PowerPoint and take a quiz. And I'm just not sure that that's really the answer. So what does this look like? We've discussed this a little bit, but this was a new experience, not just for nurses, but this was uncharted territory for everyone in the hospital, from the environmental services department to the hospital CEOs. And how do we do it differently and do it better next time? And when we think about the vicarious trauma specifically, what are those effective strategies to create and provide mental health support? The key word here, I think, you know, effective, like I said, it's been cited in many studies that nurses are experiencing burnout, compassion fatigue, PTSD, but are there really any widely practiced interventions that work? You know, what does it look like? Because we know that what we did last time wasn't effective. And I think, you know, one of the key takeaways here is, for me anyway, is to think about this, you know, level of education. I think that it's probably the most interesting finding from my perspective. How do we look at level of education and really, you know, drill down what it is about a higher level of education that helps to, you know, contribute to less vicarious trauma for nurses? Again, is it their job duties? Is their personality traits? Identifying these, I think, could be really beneficial to nurses in the future. So, just to summarize here again, vicarious trauma was associated, or lower vicarious trauma was associated with a higher level of education. Nurses that felt that they had adequate PPE had less vicarious trauma. And I think that those two things are really interesting. There weren't a lot of questions about support from administration and things in our survey, but it would be interesting to look at if that was an associated factor as well. But I think focusing on these two findings can really, really allow us to create policy and interventions that can support nurses in the future. So to mitigate these risk factors, I think education about the risk factors is going to be really, really effective. And then also looking at what does that ongoing mental health support look like, and how do hospitals do that and do it in a way that promotes health and well-being of nurses, and not just for the time being, but in thinking about Dr. Gaffney's presentation, is this is going to have long-term implications for nursing. Things that have happened during the COVID pandemic that are causing nurses to leave the bedside or feeling regret in their career choice. I think that, we're going to see, what happens, in the next maybe 5 to 10 years, but it could be very detrimental to the nursing workforce. And so I think looking at what those ongoing support systems look like and really making sure that we're implementing effective policies to provide adequate PPE to healthcare providers is going to be also really key. So that's really the meat of our study here. And I would love to answer any questions you have. And here are just a few of our resources from the study.
Thank you, Lindsay, for sharing your research with us. We do have a number of questions here. And the first is, how did the intensity of the mortality, and meaning the number of deaths at a point in time, impact the health providers differently? Is that something you were able to tease out through your data?
I'm not sure if I can actually speak to what the effect of that was, but I think that in terms of how it affected our results, because the nurses in Kenya hadn't seen their peak yet, I think it's interesting that they already had vicarious trauma without their peak. So I would, be really concerned about what has happened, because they're kind of experiencing their peak now. They started having their peak in the area where I work with nurses a couple weeks after they started getting the vaccine. And so I'd be, I hope that it's not higher than it was before, but I think that it's, something to look at. And I think that that's a really good research question for the future.
Thank you, Lindsay. Here's another question. And this is specific to Kenya. Do you think there was an effect in Kenya due to their experiencing other types of trauma, such as bombings or treating patients who've escaped genocide from nearby nations?
Yeah, I think that could be an impacting factor. The thing that I was really interested in my study is I actually expected that Kenya would have a lower vicarious trauma score, and that nurses in the United States would have a higher vicarious trauma score. And this prediction came as a result of my time in Kenya. When I lived in Kenya, we had a limited number of ICU beds, a limited number of ventilators. In the emergency department in the hospital where I worked, there was one monitor. So one cardiac monitor for any patient that showed up, or multiple patients that were waiting on a bed, somewhere in the hospital. And so I suspected that because nurses in Kenya had been exposed to this before, that their vicarious trauma as a result of the pandemic would be lower. But that's not the case. And I know that nurses in Kenya experience the rationing of resources, and they experience bombings and refugees more often. And so I think that it's something that, again, I would love to study in detail more about why this was more prevalent in Kenya than in other countries.
Thank you. You mentioned nurses working as a team during the pandemic. Do you feel that there will be a lack of understanding or teamwork between nurses who have worked through the pandemic and new grad nurses entering the workforce?
You know, I think that number one, that there already is, and I hate to say that, but I think, you know, being a new nurse, being a new graduate nurse is difficult. I remember being a new graduate nurse. It's been, you know, 11 years ago now, but I still remember feeling that I didn't have didn't have friends at work. And I also didn't know what I was doing. And I was scared that I was going to hurt someone all the time. And so I'm sure, I suspect that there will be that camaraderie that's bonded the nurses from this experience. You know, I suspect that unfortunately there will be some disconnect that's maybe even more substantial than it already is.
Thank you. One of the issues that we continue to have in the United States is that we do not have a system of healthcare delivery, which seems to be exacerbated by the lack of federal government direction. How can we better provide an organized, thoughtful strategy to identify and access needed resources across areas and regions of care to address such outbreaks?
Yeah, so this is something that hits very close to home for me. And interestingly enough, it's due to my time in Kenya, because I think about how patients in Kenya have, you know, much more limited resources than we do here in the United States. But there's also this population of people here in the United States who their social determinants of health, because they were born not white, you know, they don't have access to transportation or, you know, healthy food where they live, or you know, follow-up care and things like that. You know, I think there is not a one-size-fits-all answer in the United States because our healthcare system, as we all know, is broken. The insurance companies and the pharmaceutical companies have a lot of power. And I think that it's going to take a lot of, I mean, I don't know the answer, but I suspect that, you know, we need to start in, you know, looking at healthcare not as a business. And I think that that's a really hard thing to do, because in order to be an effective healthcare institution, you have to run it like a business. But I think shifting our mindset and creating a new framework and that focuses on helping people and not generating revenue, I, you know, would say is something to focus on. It's not the only answer, but, you know, again, I remember, you know, I had a friend when I was in Kenya, a Kenyan friend who was in an accident, and I was with her when she was in the accident, and she needed to have a chest x-ray, and it was $8. I don't know how much a chest x-ray is here, but I'm sure it's not $8. And we, you know, that she was able to pay for that out of pocket. Now that's a large expense for her, but $8 is, you know, if that's how much it really costs to have a chest x-ray, I don't know why we pay what we pay here. I'm sure there's a lot of reasons why, but again, I think there's not a one size fits all answer.
Thank you.
Okay, our next question. Nurses have suddenly been called heroes during the pandemic. Do you believe labeling nurses as heroes does more harm than good?
I don't know if it does more harm than good. I think that labeling nurses as heroes and then not supporting them would be what I think does more harm than good. You know, the comment that someone made in Dr. Gaffney's, you know, results about the administration going home every day and really not being exposed to COVID, but, you know, here's a free pizza. I think that's harmful, but I don't know what we do to change that.
Here's another question. How can new graduate nurses better understand and help support the current nurses with vicarious trauma?
Yeah, I think always trying to think about what the other person may be going through is something that is something that new graduate nurses can do. I think when you think about the experiences that nurses who, you know, worked through the pandemic and have also been nurses for a very long time, who may have already been burnout prior to the start of the pandemic, I think recognizing that and perhaps not taking things to heart if you hear someone maybe make a comment that's not directed at you, and just kind of giving them some grace. We all go through rough times in life, and I think you know, we can't always show ourselves grace, but if we can show other people grace, I think that's really helpful. I think also being aware of your own understanding, your own lacks in understanding are also key. And then, you know, maybe asking them about their experiences and allowing them to share that with you. Maybe that would be therapeutic for them.
Mm-hmm.
Thank you. As society is becoming more aware of mental health, and your research shows how important mental health is for our nurses, what do you think hospitals can do to help nurses' mental health instead of completing online modules?
Yeah, so this is something that I have looked into a little bit, trying to write the manuscript for the study. But I think providing opportunities for nurses to receive mental health support that doesn't require them to schedule an appointment with a provider that takes 3 months to get into. You know, having someone who is, you know, a designated group of people that are focused on healthcare workers' experiences and available to nurses, and perhaps maybe, you know, healthcare workers only, I think would be important. I also think that mandatory debriefings after not just traumatic experiences, but stressful experiences is very important. There's a lot of studies that show the importance of debriefing and how it can decrease burnout and stress and job strain for healthcare providers. So I think that mandatory debriefing, even though, you know, the word mandatory, I think has some negative connotations, but, you know, we can't help you if you're not there. And so I think that the benefits outweigh the risks, I think.
Thank you so much, Lindsay. One final question. And the author writes, my understanding is that N95 masks were never meant for just one use. Has that changed?
So I don't know the current literature specifically, but it was always my understanding as well that an N95 mask was single use. And so I think, you know, most nurses were under that impression as well. And I'm not sure if that changed. I know there have been a lot of studies that people have done in terms of transfer. And I think that's why a lot of facilities had nurses start wearing that face shield. And so that when they were taking off their mask, they hopefully weren't as many particles on the mask from wearing the face shield. But honestly, I don't know the answer, but it would be a really interesting thing to know for sure.
Great, thank you.
Thank you.
Okay, really great thank you to our speakers for their insights, for their research, and for helping us, for challenging us with things that we need to think about and consider moving forward. I want to remind you that our third and final session takes place just 2 days from now on Thursday, the same time, 5 to 6:30. It will be a very significant evening. We will finish strong and with a message of encouragement and hope. We will, that evening, we will have original research presented by Dr. Patricia Benner. And then we'll also look at a topic that's a very important topic that's come up in a number of the questions and presentations tonight, and that is a critical reflection on leadership during the pandemic from our own Dean, Dr. Aya Lesh. So thank you for your participation tonight. All of these sessions are recorded, and you'll be able to access them on the YouTube link once they're uploaded and they'll be made available. And you have a website that you've been provided, where you've registered, where you've been able to go and see evaluations, where you've been able to access the posters. So feel free to email me with any additional questions. Thank you all for attending, and we look forward to seeing you Thursday night at 5 o'clock.